I'd like to call the Health Committee to order. Will the clerk please call the roll?
Representatives Alexander, Boyd, Byrd, Clemens, Freeman, Gant, Hakeem, Hall,
Yep.
Helson, Hicks, Jernigan, Kumar, Marsh, Mitchell, Ramsey, Sherrill, Smith, Vaughn, Whitson, Williams, Vice Chairman Leatherwood, Chairman Terry.
Here.
Mr. Chairman, you have a quorum.
Thank you. Before we get started, do any of the members have any personal orders? Chairman Boyd, you recognize?
Thank you, Mr. Chairman. Members, I have with me today a constituent, a high school junior, and it's Mr. Aiden McDowell from Lebanon. If you'll make him feel welcome.
Okay. Any other personal orders? Okay. We have a physician, the doctor of the day, Dr. Michael Helton with Helton Family Medicine. He is the president of the Tennessee Academy of Family Physicians. He works in Murfreesboro, works in my county, and he is our doctor of the day. Give him a hand, please. All right, we have 3 items, bills on our agenda, and then following that, we will have a budget presentation from the Department of Health. So without objection, we will take item number 1, House Bill 2027. Chairman Hicks, you recognize? Okay, you have a motion and a second.
Thank you, Mr. Chairman and committee. House Bill 2027 will provide an $800 training supplement for licensed emergency medical personnel who are employed full-time for an ambulance service upon completion of 40 hours of annual training.
Are there any questions on the bill? Okay, seeing none, can you just clarify, this was something I guess came up after last committee. There is a good-sized fiscal note, but being the chair of fiscal review, of the finance committee, you may have a little input on this, but you think it's a little bit broader than what it should be?
Yes, it is. So we're actually, Mr. Chairman, we're actually working on that fiscal note to try to get that lowered down. We're pretty positive it's going to be lowered way down from where it is now, but we're still working on that with fiscal review.
Okay, and it's because they've expanded those that are retired. They put everybody on there that's not actually
that license, right? But we're looking for only active licensures.
Okay, thank you. Okay, any further questions? Okay, seeing none, we are voting on House Bill 2027. All those in favor say aye. Aye. Opposed? Ayes have it. Bill goes on to Finance, Ways, and Means.
Thank you, Chairman and committee.
All right, that brings us to item number 2 on the bill, House Bill 1956. You have a motion and a second. Chairman Crawford, you're recognized.
Thank you, Mr. Chairman. Thank you, committee. Today I have House Bill 1956 before you. This is the ambulance EMT training facilities or training centers bill. Basically, what we're doing is we're increasing the amount of students that can take the class from 10 to 20. And we're also extending, instead of 2 times a year, they can do 3 times a year as far as their classes. The reason we brought this bill is we are heavily understaffed throughout the state with ambulance drivers. We have ambulance sitting there and nobody to drive them or work. And so our citizens are not as safe as they could be. So hopefully what I'm doing is I'm going to get some more of these guys trained so Gary can give them $800 when they train. So this hopefully will fix the problem. We did it as a pilot program in East Tennessee, and it's worked out great so far. So I think this will be a big step in the right direction to do it, have them in East Tennessee, Middle Tennessee, and West Tennessee.
Okay, any questions? Chairman Williams.
Thank you, Chairman. No questions. Just wanted to thank the sponsor for this bill. I remember when he came to finance and was asking for a little bit of money for a pilot program, and it seemed like a great idea at the time, but we weren't really sure. He's here before us today because it is working really well, and so this is a job that's very difficult to fill in our communities, and by multiplying the number and the opportunities for them to do it, it's going to greatly impact Tennesseans. So I just want to thank you for bringing the bill.
Thank you.
All right, thank you. Any further questions? Again, I'd like to thank the sponsor. I think I said something in subcommittee on this, and for those at home or those that are in the audience, sometimes getting to a point like where we're at here, it's a process, and sometimes the discussion where we think we need to go, and we eventually end up there. I think former Speaker Pro Tem Bill Dunn had said sometimes the slower you go, the faster you get there. But you have worked on this, and I really do appreciate your working on this issue.
Thanks, sir.
Without any objection, we are voting on House Bill 1956. All those in favor say aye. Opposed? Ayes have it. Bill goes on to calendar and rules.
Thank you, Mr. Chairman. Thank you, committee.
All right, that brings us to item number 3, House Bill 1981. You have a motion and a second. Speaker Marsh, you recognize.
Thank you, Mr. Chairman. House Bill 1981 codifies the use of ambulance operators and clarifies that a for-hire endorsement is not needed to operate an ambulance, as has been allowed by the emergency rule and executive order during the COVID-19 pandemic. This legislation will codify the use of non-licensed and entry-level personnel to operate an ambulance. These non-licensed and entry-level operators will have no medical contact with patients above their scope. They will be accompanied by a licensed personnel with appropriate medical training, and they will be required to enter further training within 12 months. This bill creates 2 new categories of personnel. EMS-A, this category of personnel is unlicensed. EMS-A or EMS apprentice is a position intended to offer a gateway position for new recruits to work for the ambulance service while working toward a license. And an EMS-A is allowed to help lift patients on a gurney and drive the ambulance. EMR, this category of personnel is licensed at a level below EMT. An EMR can perform basic life support skills such as CPR, oxygen administration, limited medication administration, splinting, immobilization, and patient assessment. Upon employment as an EMS-A or EMR or licensed as an EMR, the employee has 12 months to enter into a higher level of training. With that, Mr. Chairman, I'll answer any questions.
Do we have any questions for the sponsor of the bill? Representative Clemens, you recognize.
Thank you, Mr. Chairman, and thank you, sponsor. And so far this session, I've seen a lot of things that we did during emergency rule or otherwise during the pandemic that we are now trying to make permanent. And I just want to make sure there's not one of those things where we're allowing people who aren't adequately trained to do a job. And I don't think that's what you're intended to do here. And I suspect we have plenty of support for this. I'm just curious as to, is the sponsor confident the individuals who will be doing this have adequate training or adequately qualified to do this?
You recognize.
Thank you, Mr. Chairman. I'm very confident in this. I've had all kinds of folks come into office talking about how good this has worked out. And also the Tennessee Ambulance Service Association has worked with the Emergency Medical Service Board and the Department of Safety to remove this unnecessary endorsement. So they're all on board with doing this. So I think it's a really good program.
You recognize.
Yeah, thank you, Mr. Chairman. I appreciate that, and that's great to hear. Thank you for this legislation.
Thank you.
Okay. Any further questions? Okay. Sina, I did want to make a comment, and that's something that you had put, and it could be towards his question. That one of the things you said into the record is one of the things I wanted to make sure is that somebody that was driving the vehicle would also be able to participate in positioning or moving that patient, lifting that patient. Because I've been in situations in the OR before that they can't touch anything and they're just standing there. And so having that they can participate in that. Additionally, I did want to point out that if this is something that this committee passed, the TANF Opportunity Act and the apprenticeship program on this, if they qualify for TANF, then they could get support through that apprenticeship program. So this goes in line with something that this committee has already done. So appreciate you for bringing this bill.
Thank you.
All right. Without any further questions, we will be voting on House Bill 1981. All those in favor say aye. Aye. Opposed? Ayes have it. Bill goes on to Finance, Ways and Means. All right, that brings us to the conclusion of our slate of bills. So with that, we do have the Department of Health come to present their budget. So with that, we will go out of session. Thank you, Commissioner, for joining us, and I think you guys know the role. I think you've presented this before. Just for the record, tell us who you are, where you're with, and thank you for joining us.
Thank you, Mr. Chairman. Thank you, committee, for having us. Happy to present our budget to you today. I'm Lisa Piercy, the Commissioner of the Department. To my right is Dr. Morgan McDonald, our Deputy Commissioner of Population Health. And to my left is our money man, John Webb. He is the Deputy of Operations. And, excuse me, and to his left, this is the first time this budget has been presented with Dr. Tim Jones. He was out with a family emergency last week. Dr. Tim Jones is our Chief Medical Officer. So I wanted to first bring to you our cost increases. They, in total, come to about $30.8 million. And so I'll give you a line item breakdown of that. One of our largest items is something that you've probably heard us talk about either in our budget presentations or in multiple other conversations we're really excited about, is our dental services pilot project. This is ultimately a 5-year project with a total price tag of about $94 million that is spread out over 5 years. This represents the first year of it, just shy of $12 million. Both this year's line item, requested line item, and the entire proposal are broken down into 3 primary components. So about 2/3 of the dollars go to dental schools to help increase the class size. Let me take a little sidestep here to give you some situational awareness. In our counties statewide, in all of our counties statewide, there are only a handful, 2, 3, 4 maybe, that have adequate number of dentists. Every other county in the state is considered a health professional shortage area when it comes to dentists. On the whole, we are about 700 dentists short today in Tennessee. And in the next 10 years, there are approximately 1,300 dentists that will be of retirement age. So let me describe to you the situation that sets up. So we're already in short supply of dentists, and there is a demand that exceeds that supply. And then as you go further, that supply gets even lower because of the retirement and because we only have 2 current dental schools in the state, and then a 3rd one coming online that hasn't started even its first class yet. So UT puts out, or UT has about 100 slots a year, 30 of which have to go to Arkansas residents because Arkansas does not have a dental school. So that leaves 70 spots in the UT school that are eligible for Tennessee dentists. And we know people from here are more likely to stay here and practice, although that doesn't always hold true. So UT has 100 slots. Meharry has plus or minus 60 slots. Neither of them have expanded class size in a very long time. In fact, UT, one of the reasons we're in sort of this, I'll call it gray wave, upcoming retirement wave of dentists, is because UT used to put out 2 classes a year. And then at some point, maybe in the 80s or in the 90s, they dropped back to 1 class a year. So this state is only putting out right now about 160 dentists per year. And there's no guarantee that they'll stay in the state, obviously. LMU is coming online. They are scheduled to start their first class in August. Their applications are currently open. They are slated to have 80 slots. I do expect that to be full. I spoke with their dean a few weeks ago. So that will help. But I wanted to give you those numbers to illustrate that we're losing the battle of having adequate number of dentists. So 2/3 of this overall dental package proposal, including this first year, has to go to, or is going to, dental schools to increase class size. And so that's the bulk of that. There's a lot of costs associated with faculty and all supplies needed. So that's the major component of the program. The other 1/3 of the funds are going to a couple of different things. One is the prosthodontics. So all of the dentures for the underserved, elderly case management for those who are 65 plus trying to navigate the dental system. But another really big component of that is recruitment and retention to underserved areas. This is the immediate piece that can help immediately, because even if you expand dental class size today, it's going to be at least 4 years before you recognize that investment. So when you start, so this whole approach, and if you haven't seen the report that the work group put out in October, I encourage you to do that. We're happy to provide that to you. But this is a multifaceted approach where we have more short-term solutions and then longer-term solutions. Because in that mismatch of supply and demand that I described, you can imagine if you're a new grad coming out of dental school with what is on average about $380,000 worth of debt just from dental school, not undergrad. Dental school is quite expensive. When you have that kind of debt and you have the demand in the market, it's pretty attractive to go to a suburban, heavily commercially insured area, because that you can recoup your investment from dental school much quicker, and can have some of the lifestyle that you want. So there is a pretty easy path to the areas that may not need the dentist as much. And so it's really important for us to be able to incentivize new dentists and even existing dentists to go into these underserved areas. I'm sorry I'm taking a lot of time on this. I just get pretty passionate about it, because you just really can't fathom all of the trickle out effects from this. So it's pretty easy to make the connection between oral health and physical health. You know, if you have poor dentition, it oftentimes bleeds over into poor physical health, or those kind of go together. It might be a little more of a stretch, but you can understand that poor dental health can lead to poor economic health. If you don't have a presentable smile, a good face to the world, if you will, not only you might not feel well, but you might not feel confident enough to work in an environment, or frankly, might not be hired in an environment to where you can economically prosper. Well, then when you take another layer out, if you don't have adequate dental care, you're still going to have dental problems. And if you don't have a dentist to go to, the only place to go to is an emergency department, an ER, oftentimes in rural areas. Rural EDs don't have dental expertise on staff full time, most likely. And so about the best they can do many times is stop their pain until they can get them in somewhere. So you've got the excess cost of an emergency room visit that was unnecessary in the first place, and then even potentially some opioid issues if there are if there's extreme pain and there's really not much else to do about it. So there's a whole lot more effects than just saying, oh, your smile looks pretty or your teeth look nice. There's a lot bigger health and public health and economic health ramifications of this. I apologize, Chairman. That was a long-winded explanation. I only have 12 more items to go. So that was number one. The rest of them won't take that long. So this proposal does not have any FTEs associated with it. I did reference the stakeholder group. This was something that the governor asked us to convene back in the spring. We had a stakeholder group of about 22 or 24 folks, almost all from the private sector, with the exception of our department and TennCare. We had payers, we had private dentists, we had the dental schools all come together and lay out this multifaceted approach over 5 years. I encourage you to look at that report if you haven't seen it, called the Healthy Smiles Initiative. Number 2 on our list is a provider rate increase for our safety net providers. And just as a quick reminder, when we say safety net, that's a term that we use to mean providing for the uninsured. So we administer the safety net fund, and this would be a provider rate increase in the amount of just shy of $2.2 million. The number 3 line item is for 4 new FTEs for environmental health specialists. These are essentially restaurant inspectors. So we have had significant, but when you have more restaurants, you need more restaurant inspectors. And we've sort of maxed out the ones that we have. They each are carrying a caseload of between 1,000 and 1,200 restaurants each, whereas they need to be around the 800 mark. So this would be adding 4 new positions in order to account for that increase in volume. Similarly, we are requesting 2 FTE positions for administrative positions in our Board of Nursing. These are positions that are actually filled right now, but they're filled with contract employees, and we're having to use them so much that the finances have gone upside down, and it would be more advantageous to put those on the payroll. Numbers 5 and 6 are in our health licensure and health-related boards in our field investigation positions. These are paid for through board fees, but those are passed through as state funds, but these are covered by that. And this is also pursuant to the increase in caseload and to try to speed up throughput of our licensees and their processes. Number 7 is one that is extraordinarily impactful and important, and that's our suicide prevention director position. That position is currently filled, but the short-term funding does expire this year. So we certainly want to continue that and are requesting sustainable funding for that position. Number 8 is a position in our public health lab in bioinformatics. If you aren't familiar with that term, those are the folks who do the genomic sequencing of variants. I'm pretty sure you're familiar with what a variant is. And just for the record, there are variants in things way more than just COVID. And in all seriousness, as our technology evolves and we have the ability to do sequencing and more specific identification of these viral variants or genomic variants, this is something we can do to that our industry can do to target therapy. So very important position there. Both number 8 and number 9, you will see those are 0 FTEs because those are reclassed current positions. Number 9 being a new general counsel or attorney position in our Office of General Counsel due to the increase in caseload. As you can imagine, we have a massive amount of records requests, investigations, other types of legal work, heavily influenced by the pandemic, and so we need an extra position there. Number 10 is our largest line item this year, which is $15 million for an upgrade to our LARS system, which is the licensing system. This does come out of the dedicated board reserve fund, so it's not state dollars. And just as a reminder, our board fund is populated by the fees from all of the different boards, and it is prorated based on how many licensees are in each one of those boards. So our licensing system is online. I believe this was the current product was when we went from paper to electronic. For those of you who are in the medical field, you kind of know how difficult that transition is to begin with. But now this is taking our current electronic system and making it much more user-friendly with the mobile app and one that can be supported. The customer support and tech support of our current system is already on the wind down. And so we are going to be putting this out, obviously, competitively for a new system using dedicated board reserves. Number 11 is a small line item that will help us improve our data analytics in our Office of Informatics and Analytics. We do a tremendous amount of data collection and analysis across the department, even though the OIA office primarily puts out a lot of our substance use and overdose data, which is exceedingly important, and they need some additional software capabilities to do that data analysis. Number 12 is one that is an addition to last year. So this works up our routine equipment replacement cycle in our lab. It takes it from $500,000 a year, adds this $500,000 to make it $1 million for routine replacement of our lab equipment. If you've never been to our state public health lab, I would love to give you a personal tour. It is a super interesting and impressive place. I had the privilege of taking Chairman Watson out there a couple of Mondays ago. And I think he was also pleasantly surprised at the very vast amount of work that they do out there. They're pretty hard on that equipment because they use it a whole lot. And so in our 10-year replacement cycle of equipment, this will take us from $500,000 to $1 million, which is where they think they need to be for routine equipment replacement. And then the last one is a payroll realignment in OIA. that data analysis office that I referenced a minute ago. This is a realignment from federal sources to state sources. We have federal funding now, but many of the federal grants that we use to pay for payroll are restrictive in what those personnel can do under that grant funding. So we're going to retain that grant funding, but use it for a different purpose other than payroll to free up the restrictions on those employees, and requesting state funding to backfill that payroll expense. So again, the total is 30.8 million, with just over 16 million of that coming from dedicated state funds. When we were in House Finance a week or so ago, they asked us to present the big buckets of non-recurring funding that's going to expire this year. So on the state side, we did get an additional $3 million in safety net funding that's going to expire this year. And as I told them, we are exceedingly grateful for any amount of money put in the safety net, because this is how we care for our uninsured and most vulnerable population. But I will admit that while we're glad to have money in that fund in any shape, form, or fashion, it's pretty difficult to have it in a non-recurring way, because that forces us to do one of a couple of different things, neither of which are palatable. One of them is we can bump up rates for the providers that are in the safety net for a temporary time. And then they adjust their business cycle based on that additional rate increase. And then when that non-recurring funding goes away, they have to go back to the lower rates. That's difficult for somebody in operations. Likewise, the other alternative we can do for one-time non-recurring funding is we can bring new safety net providers onto the rolls, if you will, to expand access. That's great, more providers. But when that non-recurring funding goes away, those providers are there without funding, or they potentially have to stop seeing those patients because of that. So safety net funding is a double-edged sword. We really it goes a long way, and we're good stewards of it, and we appreciate any dollar we can get. But we do much more appreciate recurring funding because of what I've just described. The other non-recurring state level funding that's going to be expiring this year is $2.4 million in direct appropriations. Many of those were, interestingly, dental initiatives where we had several one-offs on oral health things. And we just didn't wake up one day this year and decide to start working on dental initiatives. We've been trying to do this over several years because we recognize the need, but it has been in somewhat of a piecemeal fashion, which is why I so much appreciated the governor asking back in the spring of last year to convene all of the stakeholders to get this comprehensive approach. So many of these direct appropriations were in that space, and they're going to be rolled up into this bigger package, so that we're pretty comfortable with that. On the federal side, we do have a very large chunk of money that is non-recurring. Fortunately, this is able to be carried forward, some of it even as far as 25 and 26 if needed, and so we're not particularly concerned about that. It takes quite some time to process and spend that amount of money, but we're well on our way there. And then the other one is just a very small bucket of interdepartmental grants, the biggest of which was a criminal justice program. House Finance also asked us to kind of cover a few of the big buckets that we have done with our COVID relief money, the federal funding. And certainly this is not an exhaustive list, but probably the three biggest buckets you may have heard of, but I wanted to highlight here. So one of them is what we used to call hospital staffing assistance grants. You've probably heard of me talk of that before. You'll notice that it's now called healthcare staffing assistance grants, because we are able now to expand that into nursing homes and long-term care who have duly been affected with all of the fallout from the pandemic. So I won't go into a long monologue about why staffing has become so expensive and difficult in healthcare. Some of the reasons are the same reasons that all industries are having workforce issues right now. But one of the things that's particularly unique and difficult in healthcare is you've probably heard of the contract agency. So, staffing problems in healthcare settings didn't start 2 years ago. They started a long time ago, particularly the nursing shortage. But certainly exacerbated by the pandemic. Well, what did we do with nursing shortages before the pandemic? Well, we just used contract agencies. Well, that's what everybody's doing now. And therefore, as we're talking about supply and demand, when that demand goes up, the price for that service has skyrocketed. Whereas when I was running hospitals, we might pay $60 or $70 an hour for a nurse, which was more than the typical rate of 35 or 40 for an employed nurse. So there's a premium on that. But at the height of the pandemic, at the height of that competition, those fees could be upwards of $200 and $250 an hour for nurses. It doesn't take a healthcare finance expert to understand how unsustainable that is for hospitals. They are faced with having to find staff, but yet at this super expensive rate. And so our hospital and now healthcare staffing assistance program helps to offset that. And you'll see the amount here of 120 million. That's out of the ARP funds. We actually mobilized about 50 million out of CRF prior to ARP. So the total is about $170 million that the department has passed along federal funds to our local healthcare providers to help offset some of these staffing costs. The second big bucket is one that I'm particularly proud of, and I bet you have heard of in your districts. If you haven't yet, you probably will. And this is where we are dedicating just shy of $130 million to repair, renovate, or in some cases, replace our infrastructure at local health departments. So local health departments, generally speaking, are owned by the counties, and many of them are quite old and quite in disrepair. But if public health does anything well, it is do a lot with a little. And so I hardly ever hear complaints. They're fine where they're working, but not only our employees and certainly our constituents deserve better. They deserve a good place to go, and in some instances, a safe place to go because some of them are quite old. So this about $129 million allows for a minimum of $450,000 for renovation at all 89 rural health departments. So if you haven't heard from your local mayors about this, you probably will. I've heard from many of them. They are super grateful for that because particularly some of these smaller counties do not have those types of funds. This does leverage a small match with the county ARP funds and sort of us both having skin in the game to invest in those health departments. This also includes 17 county health departments, are the ones in worst disrepair, a full replacement of those. And those are the mayors that are super, and employees that are super happy about getting a brand new building. The final one is another replacement of our state public health lab, the one that I was bragging about a few minutes ago. It is a great service and has a lot of fabulous programs, but it is in a 1950 tuberculosis hospital. It is not the most efficient design for a highly technological or technologically advanced lab, and sort of outgrown the space. The space is older and in disrepair. And so this would be using the one-time federal funds to replace that capital. And then before I leave you, I want to make sure you know that we do more than COVID at the Department of Health. Sometimes it feels like that's all we do, but we are super excited about getting back to non-COVID work. It's important work and we're going to continue doing it, but we've got much bigger and broader priorities. Just something to maybe reference some comments I made earlier. Actually, in our department, in our mission of the department, is not only what you would expect to protect and promote and improve the health of people in Tennessee, but also their prosperity, because we know that if they are not healthy in every sense of the word, physically healthy, emotionally, mentally healthy, that they are not going to reach their full economic prosperity potential. And so we want to goals of prevention and action is something that is just the bread and butter of public health anywhere, and it's the things that you think of when you think of public health. But specifically, we have detailed out in our 4-year strategic plan about the different metrics that we want to try to improve. One of those is local health metrics using a locally driven process through county health councils and county health assessments. We recognize, as I that what works in Sullivan County is not necessarily what works in Lawrence County, and all different types of scenarios across the state. We have a very diverse state and diverse healthcare needs. So using the local level and the local folks to do those health assessments and help them target interventions. One of the primary causes of morbidity and mortality in our state is obesity. And we know that children who are obese are much higher risk to be adults who are obese. And so targeting that youth obesity in children, one of the most evidence-based ways to do that is through WIC participation. And WIC is the Women, Infants, and Children, the food program for pregnant mothers and young children, and driving that participation and maximization of that program, as well as through our Office of Primary Prevention and the built environment. So access to greenways and playgrounds and spaces where particularly children, but all individuals can move and get physical activity. And I'm sure it comes as no surprise that one of our primary goals is to decrease tobacco use. That is not only initiation in young people, particularly as it pertains to electronic products, but also cessation services for adults. One of the programs that you is the Baby and Me Tobacco Free program, which allows for diaper vouchers for pregnant moms who stop smoking. Or their partners in the home. So if you've ever bought diapers lately, they're quite expensive, and they are not covered through any of the other governmental programs. And so this not only improves health outcomes for mom and baby and partner in the home, but also incentivizes that through diaper vouchers. Another one of our prevention objectives is to decrease substance misuse. A very important component of that is the data analysis and the overdose surveillance that I mentioned earlier. Unfortunately, our overdose trends have gone in the exact wrong direction during the pandemic. I'm sure you can understand why that is. It is multifactorial, but we've got a lot of work to do there. And then you've got two pediatricians sitting at this table, and so you'll know that adverse childhood experiences are near and dear to our heart because we know how very impactful they are, not only on children, but for the entire lifespan. So childhood trauma, trying to prevent that, and in situations where it already exists, trying to mitigate the effects of that through things like evidence-based home visiting, care coordination, and supporting young families. And then finally is our second piece of our strategic goals, which is access. And I'll remind you that we're in a bit of an unusual situation, actually a very unusual situation in this state, in so much as the State Department of Health serves as the primary care provider for a large portion of the uninsured in Tennessee. So I mentioned earlier, we sometimes call that safety net. There are safety net providers outside of the department, but it's pretty unusual. And in over 3 years in this role, I have not found another state that is providing primary care through the State Department of Health, at least not at scale like we are. At last count, I'll say a rough number, we have 56 of our 89 clinics have primary care in them, of which about, I think, around 16 of the 56 are FQHCs. And so we not only provide public health, but we provide primary care. And that's something very unusual for a state health department to do. And it doesn't always exactly align with the public health practice in that same clinic. So different patient throughput, different patient needs. And so it forces us sometimes to pick, well, are we a public health clinic that's doing primary care, or are we a primary care clinic that's doing some public health? We tend to lean towards the former, but knowing that we have to balance both of those. That's been, frankly, a challenge in choosing an electronic health record because nobody else is doing both of these things. So it's hard to kind of get that. It's also hard to get your throughput processes efficient because you're dealing with two simultaneous processes happening concurrently in one location. So one of our big access initiatives is to improve our clinical efficiency. That's basically being able to serve more patients without additional resources. Just doing, I hate to use the cliche, doing it smarter, not, doing it better through doing it smarter, not working harder or adding more to it. Then likewise, for those who don't seek care in our primary care clinics, we want to improve the healthcare access for those in the community using primarily our safety net providers. We have an excellent group of safety net providers across the state. And just like public health, they are very accustomed to doing a lot with a little. And so we want to do what we can to help support that and support them not only in their efficiency and their sustainability, but also in their outcomes. So underserved and uninsured patients absolutely deserve the same outcomes that commercially insured patients do. And so we want to be able to help our safety net providers support those good outcomes. In this also includes our provider recruitment and retention to rural areas. You've probably heard of our Tennessee State Loan Repayment Program, which is very unfortunately called TSLRP sometimes. And I try not to say it. But that is the state loan repayment program where we do incentivize providers to go to underserved areas. That is what that dental recruitment initiative will roll up into. And then finally, more of a conceptual objective that we have is to leverage innovation in the vein of access. Some of that is tangible, like using telehealth and expanding ways that we can interact with patients, but it also means leveraging innovation in delivery care models, in reimbursement models, things that we may or may not actually have control of here at the state, but learning from our experience in providing care in rural areas and helping to influence federal policymakers who determine some of those reimbursement structures. So I do appreciate, Chairman, the indulgence of all of that monologue, and I'm happy to take questions.
All right, thank you. Members, do we have any questions? Okay, Representative Clemens?
Thank you, Mr. Chairman. I have a few questions focused on the primary care safety net. And thank you, Commissioner, for being here and others. So with the primary care safety net, and that's to what you were referring when you were referring to safety net, right?
Yes. Generally speaking, yes. It's also dental, and there are some provisions for specialty care, but the bulk of that is primary care. Yes, sir.
And so how many Tennesseans currently benefit from that program?
I will put you right over to Dr. McDonald. She's my safety net guru.
Hey, good afternoon. So approximately 162,000 adults were served by the adult primary care safety net through what we call primary care plus services. So that's actually primary care, mental health, and dental. And then we also fund some specialist care coordination, and I'm going to get that number for you as well, but it was a similar number of individuals.
Okay, thank you. And so through the primary care safety net, for example, the FQHCs, the CFBCs, and the local health departments are the only ones that can provide services through that program, correct?
I think you said federally qualified health centers, community faith-based centers, and then there are some local health departments that are FQHCs, and so it's that subset of local health departments.
Okay, and I guess my concern is that they all have unique missions and unique challenges with revenue and lack of real specialties in those facilities, and also capacity challenges. And I'm concerned our state is continuing to pour money into our primary care safety net rather than using other alternatives that could better serve that community, because the adults being served by that are primarily what their ages 19 to 64 individuals, right?
Correct.
And so there are other options available from the federal government that can serve uninsured adults in that age group. I guess my question is, why aren't we taking those federal dollars rather than allocating more Tennessee taxpayer money into the safety net to serve the same population?
That's not a department level decision. And so I think I kind of defer to the will of the General Assembly on that.
Okay. Do you have an opinion on that?
Sir, if you're discussing Medicaid expansion, as Dr. McDonald said, that's not within the purview of our department. I'll spare you the next 30 minutes of what's in my head, but affordability certainly does influence access, but it is not the only influencer of access.
You recognize?
Yeah, thank you, Mr. Chairman. I appreciate that. And I don't want to go too far down this road. I just, how much are we asking to spend on the primary care safety net, or the safety net, as you referred to it in your presentation, and how much of an increase is that over last year? Because I remember we added a bunch of money into it when we came back after the pandemic. And I raised some of these same concerns at that time because of the capacity limitations and revenue and lack of specialty at the three types of entities that can provide safety net services. So how much more are we asking this year?
The current recurring budget for the adult uninsured safety net fund is 21.9 million. There was 3 million that was non-recurring in the current year budget. There is this provider rate increase, which was designated to safety net, and we do have a pediatric different safety net, so there's some determination that needs to be made there, but the non-recurring piece is 3 million for this fiscal year that we don't have for next fiscal year.
So we're asking for 3 million more this year for that existing.
I believe in, I don't want to misspeak Dr. Piercy's words, but the recurring funding is much more, well, from a service delivery perspective, recurring funding is what's needed for the safety net as opposed to non-recurring funding.
And this year, we have just shy of $2.2 million. It's the number 2 line item on the screen for rate increases.
Because those facilities, I'm sorry, Mr. Chairman.
You're recognized.
I apologize. Is it, and that's because those facilities are charging more, or explain that to me, I'm sorry.
They are currently, they are not charging the patient anything right now, and Dr. McDonald can correct me if I'm misremembering these numbers. Most primary care visits get reimbursed about $23 a visit. I bet you can imagine that that doesn't cover cost. And so this would increase that. It's still not going to cover costs for them, and under no circumstance will they have a margin on that, but it will help offset some of the cost a little bit better.
And this was included, and John, you may want to comment on the provider rate increase that was for several health-related departments for provider increases.
Yeah, Representative Clements, I think this is part of the administration's effort to do pooled provider rate increases. I think you'll see one from DCS for DIDD, for some of the other third-party providers that I guess help the agencies fulfill their roles to the people of Tennessee.
Recognized.
Okay, thank you, Mr. Chairman. I appreciate it, and I appreciate you answering the questions to the best of your ability. I just would encourage the members of this committee and anybody else watching to really consider the fiscal responsibility that we have to the taxpayers in Tennessee. This is a population that has to be served one way or another, and we're choosing to do it through a safety net, more money every year, rather than taking other alternative funds out there that Tennessee taxpayers have already paid. So I really want us to consider that and think through that as we appropriate funds and continue this same model year after year. Thank you, Mr. Chairman.
Thank you. Chairman Ramsey, you're recognized.
And thank you, Mr. Chairman. And I want to say how much I appreciate Dr. Piercy and her leadership over the last period of time. None of us knew 2 years ago when we showed up for work what we were going to face. You've done a great job, and we appreciate it. And I do appreciate so much your emphasis on adult dental care. Since I came up here in 2009, we've been trying different methods, rural health departments and different things to assure the care, because it's such a burden on emergency medical service and a financial burden to TennCare. So I appreciate that, and I'll be of any help I can as you folks move forward. Thank you.
Thank you, sir. Appreciate that.
Representative King, you're recognized.
Thank you, Mr. Chairman. I too would like to thank you, Dr. Piercy, and your staff for the good work that you've given us here in the state of Tennessee. I have 2 or 3 questions. One, you spoke earlier about young persons, I'll say, coming out of dental school with a debt load of $380,000. And you spoke of incentives. I may have missed it, but we talked about, I heard incentives for new and existing providers. Could you give us an example of how we go about that?
Sure, I'm glad you asked because I'm remiss for not mentioning that earlier. That's primarily through the mechanism of loan repayment. And so that would be not only new grads coming out, they have all the loans right there, but many of us have been out for 20 years and are still paying our loans, our student loans. And so, when you have that big of a bill coming out of professional school, it takes quite some time. So it's perfectly plausible for someone who's even been in practice for a long time to sort of done their thing. They've served their community. They like where they are, but they're ready to do something a little more service oriented. And then they can be incentivized through loan repayment. There's also a little bit of like sign-on bonuses and other types of short-term bonus type incentives. But the primary mechanism is loan repayment.
All right, thank you on that.
You recognize.
Okay, yes, sir. You spoke earlier about a new health lab and I think 200 million. Is that just the structure or is that the equipment within the structure also?
Great question. So that is a replacement of our current lab. I believe they have done the assessment and it will be replaced on that same similar campus, maybe not in the exact location, but on that campus. And all of the equipment and viable furnishings from there will be moved over. So it does not, we're not going to need all new equipment. As we do that routine equipment replacement that I talked about, we'll just move that right into the new building.
Okay. Thank you,
recognize.
thank you, Mr. Chair.
All right, thank you. Representative Alexander.
Thank you, Dr. Percy, and thank you all for all being here. You mentioned that we would do some prevention efforts in youth obesity. That's very near and dear to my heart because I own a funeral home. The children that we buried were all obese. And I just think, I'm just curious to know how you all plan on doing that. Can you give me more insight on how you plan on promoting or healthy eating and exercise and things that we can get children eating the right way?
Yes, ma'am. If it sounds like a tall task, because it really is. And if there were a quick fix or a silver bullet, somebody would have done it right now. But it's a whole, and it's not just targeting the child, it's the whole family. And it's food deserts and which food comes into the home and which food the children are exposed to and the amount of physical activity they get. But there are some evidence-based programs. There are a lot of not evidence-based programs that we think might work, but we want to stick with the ones that have evidence behind them. So I'll ask Dr. McDonald to tell you a little bit about that, because to be quite honest, even as a pediatrician, really didn't resonate with me until I came on this side of healthcare and to public health to recognize the importance of WIC. But when you think about it, when mom and young children at home start to have those good, healthy eating habits, that does tend to continue throughout life. So I'll let Dr. McDonald tell you some more.
Happy to, and can't reiterate enough the complexity of that problem because, and when we think about pediatric obesity, we do think about it holistically, and certainly mom's prenatal nutrition, the food that she's able to buy, the food that's in her neighborhood, her ability to walk or exercise safely, and that continuing through early childhood policies. And certainly we have a collaboration with DHS around the Gold Sneaker Program, and really promoting and incentivizing those healthy policies, even in early daycare and teaching parents through that venue. Similarly, we have great partnerships with the Department of Education, promoting those healthy lifestyle and initiatives, as well as a number of grant funding opportunities for communities as they identify obesity as a rising health concern in their communities to be able to build safer playgrounds in particularly disadvantaged communities, and a multitude of other community-based interventions.
Thank you very much. Thank you, Chairman.
Thank you. Representative Smith, you recognize?
Commissioner Piercy, thank you so much. Dr. Morgan and the rest of you, the team, thank you. My colleague and I, Representative Hicks, attended your wonderful symposium on opioids and the outbreak of continued deaths as well as with methamphetamine. Would you mind speaking into the testimony and just awakening us a little more to that crisis? Because there's a pandemic that's killing people outside of COVID. So I'd love to hear your remarks on that. But also, my colleague and I have a concern that we're understanding that at the federal level, the national emergency continues to allow a lot more prescribing through televisits that may not be allowed here, and the access to buprenorphine and some other things that may be used as a help, but also is a controlled substance and has a street value. So I'd love to hear your thoughts on secondarily this national emergency, and if we're seeing a contributory factor of the federal policy harming the efforts here in Tennessee. Thank you, Mr. Chairman.
I appreciate your comments, but I'd just ask that the members keep the questions more relative to the budget, but feel free to answer. Thank you.
And I'll limit my answer to an hour, sir. Thank you.
Yeah.
It's a great question, and all joking aside, it does deserve its own hour. To answer the second question about federal policies affecting that, I am unfamiliar with any hindrances here to accessing buprenorphine now. Now, that does turn back the clock. There were some difficulties initially, which feeds into some of the overdose issues that we had. I'll talk about in just a second. Right now, I'm unfamiliar. Commissioner Marie Williams might have better information on that, but none of that has trickled my way. I think we're pretty good as far as accessing MAT right now, even from telehealth and other mechanisms. So in all seriousness, the quick overview of what substance use has done over the last really not that long, 5, 8, 10 years at most. You had the prescription opioid epidemic. Everybody was pretty familiar with that. And this committee, in fact, I think I testified back at the beginning of session about some of the TN Together legislation and how that prescribing has gone down. It's become much shorter in duration, which really helps cut down on the risk of dependence on particularly opioid naive patients. I wish that were still the problem. I wish it were never a problem. But in some respects, that's easier to deal with than what we're dealing with now, which is fentanyl. And fentanyl is an opioid. It's a synthetic opioid it does have legitimate pharmacologic use, pharmaceutical use. But what it has done, it has replaced prescription opioids as the drug of abuse. And I feel like this has been an economic seminar because it's all about price and it's all about demand. So the demand was pretty high. And then when they couldn't get prescription opioids, well, the demand didn't change. So the demand's still there and they're searching for a different thing. In times past, it might have been heroin. They could have gone back to heroin. But what came on the market because the demand was there was this very highly potent, easy to transport, and very cheap to make fentanyl, because it only takes, I'm sure you've seen the illustrations, 1 or 2 grains of fentanyl put into some other kind of powder, aspirin, some other kind of filler, and pressed in a pill press that can be easily obtained off the internet and then sold on the street as prescription narcotics. They're actually fentanyl. And I'm sure you can imagine the quality control processes in those labs are not very robust. And 1 or 2 additional grains is literally, no exaggeration, the difference between surviving and not surviving that overdose. So that's what you've got when it comes to fentanyl. So your overdose potential is extraordinarily high to begin with. And then when the pandemic started, it's kind of this combination of things that happened. So you've already mentioned there was a temporary drop in the ability to access MAT. And so people in active addiction have to get that somewhere. And if they're not being treated with their MAT, then they could go back to the street. Well, then because of all of the lockdowns and the different travel methods, if you will, the supply chain for those products was interrupted. So what the person was used to buying off the street, no longer they were able to get, and so they had to get something else. And then you combine the stress of the pandemic and the increased demand because of that stress, you saw our overdoses skyrocket in the first few months of the pandemic, and they've come down some, but they have continued to remain very high. Likewise with methamphetamine, even not that long ago, 5 to 10 years ago, the primary mechanism of methamphetamine were these home-based labs. You've heard of the shake and bake method, all of that. Again, we're dealing with supply and demand. The demand is still high, but you can make it a lot, or you can import it a lot cheaper than you can make it. Our neighbors to the south, as well as our neighbors overseas, have found that they can ship it into this country at a very low price, and it will be distributed quite easily and inexpensively. Methamphetamine is another one that has some significant overdose potential and is oftentimes combined with opioids, and particularly fentanyl, which becomes a particularly dangerous situation. If memory serves me correctly, over 70% of our overdose deaths have more than one substance on board. I'll stop there, Mr. Chairman. I'm sorry, but it's an issue that is certainly one that we need to get back to full force.
Thank you. Representative King, do you have another question?
Thank you, Mr. Chairman. I'll be brief. We have, I believe there's some statistics that say there's young people tend to want to live where they go to school, college. And if I understand correctly, we have 30 slots from Arkansas. Do we have instances where young people say, I'm going to stay in Tennessee? And what happens in a situation like that?
Yeah, it's a great question. And that's actually sort of the impetus behind some of these loan repayment programs. Sometimes they stay around the school, but oftentimes, if you can get at least 3 years, there's a good bit of data about how much more likely they are to stay permanently. So if we can incentivize folks to go to those underserved areas, and in the span of 3 to 4 years, which is the commitment to pay that off, they've established friendships and churches and neighbors and schools. They're much more likely to stay in those communities. Some of them do leave after 3 years, but trying to use an evidence-based approach to get people to go to that area. The other way to get people to serve in underserved areas are to recruit people from that area that are going back home.
Okay. Thank you. Thank you.
All right, thank you. All right, seeing no further questions, I want to thank you guys for coming and giving us your presentation. Always a pleasure to have you before the committee. And I'd like the committee to know that, in your discussions about access and rural provider recruitment, it's not just here. I've had you guys in my office trying to think outside the box what we can do. So again, appreciate you guys being here. And if any of the members have any follow-up questions, I'm sure they know where to address them. So thank you. So with that, we will go back in session. And seeing no further business before the committee, we are adjourned. Thank you.